push it over to the G
Okay.
drive. And then I had originally set up the meeting. I don't trust this yet, so you may check on it. And that is, I um, have it doing the AI summary part as well.
I
So
did
that,
uh I did get something to that effect.
okay, okay. So that's what will create, what I hope to create our recaps from.
Right.
So,
You're talking through both like the AI notes and the recording. Because Aaron, are you going to
yes,
do that? Yeah. Or John, have you already said it, started it?
Aaron has.
I mean,
So,
I don't really know where it goes or what it does. But I did see something or how to even look at what is happening.
yeah, usually like you as host will receive a copy in your Zoom folder on your desktop of the chat.
Okay.
And so I'm assuming that it will be the same for the AI summary.
Okay.
Yeah, I tested that a couple times. I can't remember where it went to, but so
The only other thing, other than getting it recorded, is um, to be able to take attendance. And Aaron, you seem to always do that, so I do as well.
Yep.
And one of the ways I um, try to keep track, because can never write quickly enough as people are kind of introducing themselves. I end up showing the participants frame and doing screen prints that I can go back to and pick up from that.
Hmm. Okay.
Um,
I
Matt
guess in theory you
Wilson,
could rewatch the recording and pull up that information if you did miss anything, but I guess that's a challenge.
correct.
Yeah.
Yeah, no, you're right. Um, I'm gonna probably sign off here in a second.
Okay.
The Matt Wilson's one of our presenters today. Um, has contacted me already this morning, so he's raring to go. I haven't heard anything back from Flint Tuition other than I think it was forget one of the two principals there actually responded with an affirmative for attendance today. So I'm assuming we're covered for the other presentation as well. I have a just with respect to um, yeah, I have an AI button flashing here, and it says AI
I do.
companion features have been enabled, and that includes meeting summary. So you should
Oh,
be
up
good
at the
there.
top of the screen,
Yeah.
that little,
I've
yeah, I
got
see
Yes,
that.
that. Yes, it too.
yeah. Um,
Now, oh, what do you do when these AI note takers request to record?
I have
Fireflies.ai
typically
note taker Robert.
right. I have typically denied those, but uh, actually the jury's still out on that. I really actually could have used them the last time when we missed the video. So um, uh, it's up to you guys.
Okay.
If you need me, I got my phone right beside me, so just let me know.
All right.
Thanks,
Thanks,
John.
John.
Okay, thank you. I really appreciate you guys' help.
Yep. Oh, no
Bye now.
problems. Even though Aaron, since you are kind of here and set up, I may let you just take if you want to
Yep.
just do the meeting, and then I may even need to switch to my phone and go on head on over to Keystone for that.
Yep. I think that's a good idea.
Yeah. Which, by the way, Steven just showed up. He's Clint Tuition, so that's
Oh,
we're
great. Hi,
Hey,
Steven.
Steven.
Hey, good
If you
morning.
might stay just for a second, Jim, because I want to go get a
Yeah,
glass of
yeah,
water.
yeah. No troubles.
Jim, how are you doing?
I'm doing well. How are you this morning?
Good, doing well. Thanks again for having me for this
No,
presentation.
yeah, we're excited to have you guys go. So it's been kind of a little bit chaotic. So we got our invite out later than normal, but
That's
hopefully
okay.
we'll have a good crowd. I mean,
That's
people are
okay.
used to this happening.
Yep,
Even though,
same.
including me, I'm double booked. I'm supposed to be at another meeting that starts in 2 minutes. So I think Aaron. So instead of me leading, I think Aaron's going to lead, and I'm going to switch over to my phone and go to my other meeting. And so it's one of those, chaos. So let's listen
No
in on
problem.
you guys, but we'll let Aaron do the
Yeah, not a
kickoff.
problem. No, I'm excited.
Good morning, Jenny. Good morning, Sherry.
Good morning.
Morning.
Greetings.
All right, Jim, you can head out.
Right, I'll switch over and go to my phone. All right, thanks, Aaron.
Yep.
There you go.
Hey, Steven.
Morning, Sherry.
Good morning.
I'm just gonna verify my slide share correctly.
Oh, fantastic.
Is that showing up okay?
Yep.
Mac always, like when it's on the sidebar, it always looks really fuzzy, and then it's like, did it show up?
We'll give people just another minute or two as people continue to join. If you want to indicate your affiliation in the in your name, you're certainly welcome to do so. All right, well, as people are joining, we can go around and do intros. My name is Aaron Deacon. I am the managing director here at KC Digital Drive, and I'm our third string host today. John is on vacation, and Jim Jim Starsiv had a conflict. So pleased to be here on camera and a little more active. I usually try to listen in to at least part of these, but I'm not quite as active a participant as I used to be. So happy to be here. Excited for our presentations today. I'm going to kind of go down the participant list, and I will call on people. It's mostly in alphabetical order. I don't know if everyone's participant list shows the same way, but let's start with Cecilia Saffold. If you just want to introduce yourself and who you're with. Okay, Doug Cahulan.
Sorry about that. Yeah, Doug Hohulan. Yeah, I'm on the Kansas City AI Club. I'm the humanities chair.
It's great. Paul Bashore.
I'm Paul Bashore. I'm with Mid-America Regional Council. I'm a data systems administrator here and just checking it out.
Great. Danielle Jones.
Oh, good morning. Daniel Jones, Association for Women's Health, Obstetrics, and Neonatal Nurses.
Great. Thanks for joining. Dan English.
Hey, Dan English here, program manager, project coordinator at the University of Kansas School of Nursing.
Bob Wald.
Hello. I have my own company, Innovation. I help companies get better using proven innovation frameworks, tools, technologies, and some aspects of AI that's built into that as needed.
Ryan Keller.
Hey, good morning, Ryan Keller. I'm co-founder of Medicare Simple. It's an on-demand education and enrollment navigation platform. Thanks for having me.
You bet. Erica Anderson.
Hi, I'm Erica Anderson. I've been to a couple of these meetings. I'm currently the executive director of the Right Connection Foundation. We are an organization that funds the uninsured, currently at the point of 911 and EMS. They never have to pay a bill. We remove all barriers to actually receiving care, and there's no eligibility requirements. I'm here based in Kansas, and I'm also a county commissioner as well in Douglas County.
Great. Gretchen.
Good morning, Gretchen Nice. I work at Children's Hospital Association and I am a manager of member engagement. Happy to be here.
Jenny Marshall.
Hi, I'm Jenny Marshall. I work at Children's Mercy. I am part of Strategy, Innovation, and Partnerships, and I'm glad to be here this morning.
I think Jim Starsiv is on the phone, and I think he's driving, so I'm not going to ask him to come off mute necessarily.
Actually, I stopped. I'm here. So
All right.
hi, it's Jim Starsiv, part of the KC Digital Drive team. So.
Julie Culbertson.
Hi, Julie Culbertson. I'm a former federal health policy wonk turned social innovator, and I presented about my nonprofit, the Trustery, that educates adults about youth mental health a couple of months ago.
Great. Thank you. Kevin Mills.
Hi, Kevin Mills here, president of Ad Astra Bio. We are a nonprofit trade association that represents the life sciences industries, kind of across the spectrum of life sciences industries in Kansas.
Kinley Yangzum.
This is Kinley Yangzum. I'm a community health worker at the Community Health Council, and I'm glad to be here.
Ron White.
Yeah, I'm the director of systems at Samuel U. Rogers Health Center. I'm just here to learn.
Sherry Tahid.
greetings. I am the community health worker at Ivanhoe Neighborhood Council.
And Whitney Henley.
Good morning. I'm a research analyst at the University of Kansas Medical Center in the Department of Telemedicine and Telehealth, Center for Telemedicine and Telehealth.
Great. Thank you. Lucia.
Good morning, everyone. This is Lucia. I'm the Associate Director for Social Determinants of Health and Maternal Strategies for United Healthcare.
Great. Come back around to Cecilia, if you're available to come off mute.
I am, thank you. I was having a little technical difficulty earlier. Cecilia Saffold, CEO of Health Teamworks. We're a nonprofit that supports healthcare organizations in quality improvement, org development, and workforce development. Thank you.
Great. Thank you. And we have three others that we won't have introduce themselves right at the beginning, but we'll say Stephen Gradwell and Jared Staphos with Clintuition are going to be our first presenter. And we have Matt Wilson, who will be our second presenter. So we'll let you all introduce yourselves during your presentations. A couple housekeeping notes. We are recording this, which I think you all saw probably when you got on. We also have an AI note taker that is recording. We typically put other note takers in the waiting room so that we don't have a meeting that's half people and half AI bots. I think I mentioned this at the beginning. Feel free to put your organizational affiliation in your name in the participant list. I see a few of you have done that. We'll probably get people kind of coming in and out throughout the meeting, so it helps people know who's in the room. All right. With that, and without further ado, I'd like to hand it over to Stephen and Jared with Clintuition.
Wonderful. Well, thank you guys so much. It's good morning, and thank you for having me. I'm here to talk to you about Clintuition. At its core, it's an intuitive way to practice medicine. So it's an AI patient simulation and assessment engine designed to help learners practice more often and get immediate structured feedback while saving educators time. I'll share the problem we're addressing, how the platform works, and where we are with early pilots. First and foremost, we are a local Kansas City company, and we're really proud of that. Clintuition is built here in KC by a team that blends clinical, business, and engineering expertise. I'm Stephen Gradwell. I'm a pediatric emergency medicine physician and clinical informaticist. My co-founder, Jared Staphos, brings healthcare business strategy and experience. And Mike Koprock is our senior software engineer specializing in AI systems and application development. Together, our goal is to build credible, evidence-based tools that scale medical education. Educators tell us the biggest constraint isn't building cases, it's time. Faculty are stretched thin, and grading clinical reasoning takes a lot of effort. Learners, on the other hand, need frequent practice and detailed feedback to really improve. But what they usually get is often brief, variable comments that don't always tie back directly to competencies. The result is very predictable. Learners don't get enough high-quality, structured reps to build confidence and skill. Simulation centers with actors and mannequins are indispensable. They provide high-fidelity, standardized encounters and direct observation you simply cannot replace. But they're also episodic, infrequent, and costly. And while learners may get immediate comments, feedback is often brief and generic rather than structured and specific. It's also nearly impossible to scale beyond a few encounters per learner per session at a time, and these are often usually spaced out in time. That's where Clintuition complements these experiences. By enabling frequent day-to-day practice and providing instant rubric-based feedback that is deeper, consistent, and easier for educators to manage. We built two tightly integrated systems. First, an AI patient simulator that supports free text dialogue, the ability to request and perform focused exam maneuvers, and be able to request common orders like lab studies and diagnostic imaging and perform interventions. Second, an AI assessment engine that scores encounters against customizable rubrics and returns targeted feedback. A recent New England Journal of AI paper found that rubric-driven AI grading achieved about 90% agreement with educators, and in doing so, reduced the grading time by nearly 90%. This is a really strong signal that this approach can significantly reduce the educator burden. Now, this was zero shot, which just means one prompt, one transcript, and we are focusing on building a multi-agent, multi-step system that helps do critiques and evaluations to ensure that the overall output is high quality. And so we expect that we can even do even better than the 90%. Our goal is simple: help educators scale their impact without sacrificing quality. One of the biggest blockers in simulation is content creation. It takes a lot of time to build realistic cases from scratch. That's why we designed this workflow to be fast and easy. Our patient creator can take your existing material, like outlines or objectives, prior simulation transcripts, case reports, or guidelines, and uses it to draft the patient template very quickly. The patient template is like a script for the AI actor. It's what allows our AI to realistically become your patient. From there, you can refine the case and, most importantly, design your own rubric so that the assessment engine grades exactly the way you want, matching the way your program evaluates key measures like reasoning, management, communication, or diagnostic processes. The result, it's still your curriculum, but delivers seamlessly with realistic patients, immediate structured feedback, and far less burden on educators. So this is how it all works. An educator can select a patient in a rubric. The learner interviews the patient, performs the exam maneuvers, and can request orders as allowed by the case. The case evolves with realistic findings as the learner works towards the objective. On completion, the AI assessment engine scores against your rubric and generates specific feedback. The educator can then edit and approve the final draft of the assessment. The results are then returned to the learner, who can review the feedback. In effect, this creates a high-frequency learning loop with fast structured feedback and minimal extra grading time. Let me show you our simulation environment. You can see a video on here on the right side. In this case, Jamal is a 26-year-old who walks in and says, "I twisted my knee playing soccer. It popped, felt weird, and went back into place." I basically probe with several different questions. Tell me more about exactly what you did, any numbness, have you taken any meds, when did this happen? And he responds very naturally, giving me details like, "I did a quick pivot, I have no numbness, I took some ibuprofen, and it was about 4 hours ago when I injured myself." Notice the back and forth feels very authentic, like a real patient encounter. Again, this is not a scripted checklist and allows for a dynamic exploration of the information you're interested in. Here's an example of how we can perform exams in our system. Again, we have basically a preloaded checklist or a preloaded list of things that people can type, but you can also put in whatever exam you're interested in, and the system can interpret it. So you can see me requesting this here, and it generating things dynamically. You can see on exam, the vitals are reassuring, stable heart rate and blood pressure. The musculoskeletal exam shows some swelling, tenderness, and limited range of motion. The neurovascular exam is more concerning. It shows some diminished pulses in that right foot. These subtle abnormalities are exactly what we want learners to pick up on, and these are the details that change management. Our order entry is very similar. Again, we can pull from a list, but we can also type in whatever we want. I start with an E-X-ray, which shows no fracture, just a mild effusion. I order an ABI, which is ankle brachial index, and it compares basically the vascular ratio between the lower extremities, and it shows me that there is a decrease on the right side. That's abnormal. Again, it pushes me to order a CT angiogram. And this shows evidence of a popliteal artery injury, a common association with a knee dislocation, which is what this patient had. This sequence mirrors real reasoning using a screening test, recognizing red flags, and confirming with a definitive study. A key part of any medical encounter is providing education and guidance. In this case, I briefly explain the injuries that require urgent surgical repair, a short hospital stay, and reassure the patient that our team is working to get him back to health and playing soccer again soon. The patient, you can see, asks, "Could you tell me more about how the surgery will help me?" And this kind of follow-up makes the simulation feel authentic, and it forces the learner to practice communication and reassurance, not just the diagnostic process. Here's an example of our assessment engine output. The learner scored 81 out of 100. It highlights what they did well with the history, exam, and test sequence, but it calls out big misses like setting a monitoring plan for neurovascular checks or engaging the patient about the recovery process. The feedback is specific and actionable, and exactly the kind of detail an educator would write, but delivered instantly and scored according to the custom rubric for the educator to review. Again, the educators can review, edit, and approve. And again, the literature shows this approach can save grading time and has excellent agreement with educators. This completes the loop of, again, a realistic interaction, diagnostic reasoning, and structured feedback ready for teaching. So we're still early, but so far the signal is very strong. The people that have tested our platform consistently say that our patients feel realistic and accurate. We're now starting pilots to measure near-term outcomes, like whether educators agree with the assessments or whether it saves them time. Literature suggests this approach is promising, but we want to validate it directly. The longer-term goal, which will require more data over time, is to show that more reps with rapid feedback actually improve retention and clinical reasoning. And our pilots are the first step towards gathering that kind of evidence. Again, we're running pilots on 2 tracks. On the practical side, we're working with the White Coat Learning Platform. This is a learning management system, or LMS, where we have 2 pilots scheduled with their clients throughout this semester. And those are focused on making sure that we're aligning with the educators and learners actually need in day-to-day use. On the research side, we're planning a cohort trial with Stanford's Emergency Medicine Partnership Program. That's designed to help us dive deeper, evaluating patient simulation for realism and accuracy, and rigorously testing the assessment engine for educational utility and efficiency. The goal here is to begin to establish validity. So together, these efforts balance a real-world adoption with academic rigor, and this gives us the evidence and feedback we need to move forward. Looking ahead, we're expanding in 5 different areas. First, more encounter types, not just clinical reasoning around diagnosis, but challenging communication scenarios like delivering bad news, disclosing a medical error, or de-escalating a patient. Communication is one of the most critical skills in healthcare, and this will give learners a safe environment to practice these types of moments. Second, we want to improve analytics and content matching. By mapping both formative and summative evaluations and linking patients to specific competencies, learners can close gaps more efficiently. And this helps highlight blind spots, targeted weaknesses, and ensuring no critical skills fall through the cracks. Third, we're hoping to improve on voice and multimodal interactions by moving beyond text to incorporate natural speech and direct visuals of exams and imaging. This will make our encounters even more realistic. Fourth, deeper LMS or learning management system integrations. By leveraging standards like LTI and SCORM, programs can integrate ClinTuition seamlessly into their existing software and workflows and use the systems that their learners are already familiar with. And finally, academic publications. By formally studying realism, validity, and educational impact, we can build the evidence that base alongside our product. And in this way, we can ensure trust and confidence in our learning experience. As we wrap up, these are the 3 ways we'd love to collaborate. First, beta testers. If you or your programs want to try the platform, your feedback is invaluable in shaping the next generation of these AI patients. Second, content creation. If you're eager, we're eager to partner with educators to develop cases and rubrics that reflect the realities of your curriculum and make sure the tool supports what matters to you. And third, pilots. We're welcome collaboration with any experts to rigorously evaluate accuracy, realism, and reliability, and to publish findings together. Our goal is to learn with you and build evidence that this technology can improve training and ultimately clinical care. Thank you so much for your time. I just want to open it up for any questions that you guys may have. Thank you.
Thanks, Stephen. That was a terrific presentation. One of the things that oh yeah, Sherry, go ahead.
I wanted to ask, have you run this through HIPAA so that if students wanted to use it, or, I think it'd be great for FQHCs with clinic care because of their volume and their limited time, but like the training and of that piece, like.
Absolutely. So we are focused on FERPA, again, to make sure that we're handling confidentiality for learners. As regarding the HIPAA, what we usually do is kind of approach it how like a journal would approach publishing a case study, is that you can basically get permission if you want to use real patient information. And again, usually try to obscure some details, obviously like the name or other specific details, but focusing so that the overall encounter still is reflected. Again, we think this is a great idea overall, because I think with its practices at the bedside knows there are scenarios or situations that you've encountered that really like resonate with you over the years and really inform your practice going forward. And we love this idea of being able to kind of encapsulate that experience and deploy it onto our platform for others to experience themselves.
Well, I definitely think with the shortage of medical assistants and those support staff to providers, this could be a huge benefit. But the hurdle, I see it being personal information.
Sherry, that's a great question and point. I'm Jared, by the way, with Clintuition, co-founder with Stephen. The assessment engine and ambient scribes that are quickly being adopted, we had backburnered at some level some of the worries about HIPAA because we were on the training side. And so that's something that we actually researched a lot more, with ambient scribes becoming almost the norm overnight, given this last year's events. We'll just keep it that simple. And, it really gives us an option. So it's another area where we are starting to probe for partners or beta testers. If somebody were to have access to transcripts, we've been researching taking the necessary steps to run that through a HIPAA protocol so that we could do real-time analysis on actual patient flow. Obviously, we could review 100,000 visits in the time and create markers for different providers and follow-ups, and something that's just not realistic in today's medicine.
And Jared, to follow up on that, are you saying that are you looking for an ambient scribe pilot partner who has that kind of data that you could use for training your model on?
It could be them, or Stephen would probably speak better to it. One of the bigger challenges is institutions aren't actually retaining access to their transcripts. But if you look at our transcripts, and we're running it through our assessment engine and custom rubrics by an institution, if you had an institution and you had your transcripts, you could create your custom rubric and immediately evaluate all of your transcripts, which is, we imagine what would happen in a real life scenario is somebody would say, I want to create a baseline on all my providers. And then from there, they would spot check and or run certain percentages on people, especially if they're giving them feedback and following up to see if that feedback is being implemented. Stephen has lots of thoughts as a provider himself about how that could be extremely beneficial to himself and others.
Yeah, I don't know if anyone's used the ambient scribes clinically, but I've had the opportunity to use Dragon Ambient Experience. And while kind of plugging around with the software, I found the transcript tab, and it shows like, I said this, patient said this, I said this, and this mirrors exactly what we're seeing in our Clintuition transcripts. So we envision that we can use these types of transcripts and feed them through our assessment engine in obviously a HIPAA compliant way, and provide basically assessments of those transcripts of real clinical encounters. And in doing so, be able to give feedback on maybe communication, empathy, diagnostic reasoning for people that are practicing in the clinical environment, not just in simulation environment.
Yeah, that's really really interesting. And interestingly, we had looked at trying to get this a local company called CarePilot that is an ambient scribe, relatively new startup, maybe a couple years old, that we were hoping to get on today to present a second, but weren't able to close that loop. But
yeah, I think they are going to be on next week or next month, though. So
Okay.
I think that's the plan
good.
right now.
Good. Thanks, Jim. I'm curious, the idea of different rubrics and of different sort of ways that different organizations or individual providers might want their kind of Q&A flow to go. Have you built that out? I mean, do you have like sort of how does that work in your platform in terms of, maybe provider A would like the conversation to go this way and provider B would like it to go this way, and so they're either training in different ways or measuring against different things. How much of that have you seen or done in practice, and how much of that is yet to come?
Yeah, so we built the whole framework out, and we have an AI agent that helps you basically kind of goes through the building process. So we've broken into the basically domains and items and then descriptors. So you can very explicitly spell out how you want to score that particular item and how those items kind of coalesce into an overall domain. And so this allows you to kind of build exactly what you want as an educator. And then the assessment engine takes that instruction set and goes through and does its thing where it breaks it into various local experts that can then grade each of the domains, evaluate its process, and then kick out the actual overall assessment. So we are working right now with our pilots to actually see how our educators want to use this to see if there's any issues with that design process. But again, right now it's very open and dynamic, and they can build what they'd like.
not to interrupt, but I think this is a very ingenious idea, and I would encourage you maybe to reach out to Dr. Tyon Lee, the chancellor at Metropolitan Community College. They are working with University Health as well as, I believe, Swope Health Services to create a fast track training program for medical assistants and other needed provider assistance. So that might be a way of entering, they collect that initial data and that training. Maybe there's something that you all could flush out there. They do have a SIMS lab at MCC. I know you want to do bigger and greater things with MDs, but this might be a
Yeah, we are not limited to MDs only. I mean, I
okay.
am an MD and I practice in the emergency medicine, so I think a lot of the ideas kind of stem from my own clinical experience. But we see this as any type of communication scenario in healthcare. That is every specialty, every type of role. And again, it really is this opportunity to be able to focus on the communication process and the reasoning process. So I think this touches every type of clinical scenario. And again, we are trying to design our simulation countertypes to reflect that. So we've been working with PTs, chiropractors, naturopaths, RNs, as well as again MDs and DOs and
So they're
APPs.
doing, not to cut you off, they're doing a training and working program. So some of the students will be students as well as working at University Health and Swope, and then part of that training time would be their clinical hours. So that might be a way of, test piloting it in community health.
Yeah, and absolutely. We're looking for the opportunity to do that. We're a self-funded, passion-driven company. I mean, this started because Steven's desire for the last 15 years to tell me every idea he had on how to change the world, and me saying, not yet, not that one. That one's too expensive. And so this was obviously we started over, well, has it been over 2 years? I'm not actually sure if we clicked. I
We
think
hit
it's
the
clicked
2-year
over.
mark
It's
in
been like
August.
2.5 years now. So
Yeah.
we were a little early to this before the ability to even do what we're doing was available. Stephen was kind of doing mock tests saying, I think this is something that'll be. So we actually started working on Clintuition before we could access the APIs required to do it. And so right about the time we finished our app ready for the APIs, they released it like the next week. So we've been playing with it for a while. So finding real life scenarios where it can make positive impact is incredibly important to us. We are, starting to feel the need now that we are very confident in what we have, what we've done, and gotten in front of people to transition to look to rapidly get it out there and test in more environments. And we are really looking to um, start to scale. I mean, we have a pretty clear idea of what we want to do this next year or two. And so that's kind of new for us since the last 2.5 years was kind of watching the tools develop and then learning how those tools would affect us rather than, being able to just go sit down and start from today, which is a very different scenario.
Well, I definitely in my head see MCC and that program that they're partnering with University Health and Swope in the training and at work model, learning and implementing is definitely a way to get more case studies or test runs.
Absolutely.
Hey, Stephen, Jared, I was wondering if you have pondered pairing this with, say, millions of images that are clinically developed, maybe extracted without patient information, that in context of what you're doing to show the need, to show the injury, to show the whatever it is that would be useful. These could be and maybe it already exists, that this has already gone through minds of, say the Cerner information or whatever databases, that you grab a whole bunch of clinical information and then you're looking at that in context. So you're presenting it in real time, just pulling things up from the cloud. Video would be a little bit too much, but to get the context, you're using metadata. Is that something that you're both pondering as a next step, or the third step?
Absolutely. So we're looking at two different things. One is like in our patient template, when an educator is building an actual patient script, is that they can just upload the images they want. Of course, either HIPAA compliant or the generated items, but they can directly link the images that they want to show. That's probably the most realistic path right now. I've been closely following just some of the Meta AI generative image generators. And I don't know if you guys remember when like the GPT or ChatGPT's image thing first came out. I'd ask it to make EKGs, and it was just like scribble lines. It was horrible. And already now it's starting to actually show like STEMIs and things like that. So I mean, like I'm optimistic that we'll be able to just generate them in the same way that we're generating the descriptions of chest X-rays or another diagnostic studies. We'll be able to just generate those on the fly. So that's probably the longer term solution. Again, we're paying very close attention to those and trying to balance, does this increase the value of the overall simulation, and does it raise the cost too high, right? I think as you start to move into voice and audio, or sorry, voice and imaging, you start to kind of rapidly increase the price compared to text. And so we're trying to find that sweet spot where we really focus on the key things that matter with communication and then add those features as they become commercially viable.
Good, thanks.
Absolutely. And I saw someone shared this Microsoft study, the MAIDXO. Amazing. I love this study. I saw this the day it came out and have been raving about it. I think this is like exactly, could be a really cool environment for testing the AI agents that are pretending to be doctors or actual medical providers, and using our platform like this to kind of bring those cases to life. Again, they took the New England Journal case conference studies and basically just made them interactive. And again, it's very similar to what we are working on. Again, they just did that for the 350 cases, but again, I think we built a system that allows you to kind of build a lot more features into it and not just take the basic case studies.
Yeah, that was kind of my question is, so your technology is more on training of the clinician, is that correct?
Correct.
But can it also be used for helping to reduce diagnostic and treatment errors?
That is the dream.
Well?
I mean, that is what I personally hope for. I get to work with, fellows and residents and seeing them kind of begin to build their diagnostic process. And my hope is that this creates an environment for them to do that. So I even noticed when I first started testing out this idea and building patients with it, I would find myself thinking about the patients that I digitally saw and the feedback that I received from the LLMs, and was like, man, this is actually crossing through my head when I'm seeing real patients. So my hope is exactly that, is that this creates those pauses that kind of help to reduce diagnostic errors, and I hope I can improve that someday.
Yeah, and Doug, Stephen's background and some of his specialty, that, because we've kind of dove into this, and then people can go research us if they want, but he's gone through a master's in research in informatics and also focuses career-wise. He does clinical decision support tools. So whenever we're doing anything, we honestly started in the simulation environment as part of when we sat down strategically. 2.5 years ago, if we said the word AI and healthcare in the same room, people would roll their eyes at us, like that. It was just like a shutdown, like, how dare you talk about AI and healthcare? And then, it's a little different all of a sudden. And so it's changed very rapidly, and some of the adoption and realizations of what it can do. So that is something where from the get-go, if you think about what we've designed and each feature and every piece of code, it's designed in a realization that it's actually the easier path forward, and it was highly more acceptable to get people to play with the software to eventually be able to look more into the actual clinical side. But the acceptance of the idea that AI is going to be part of clinical care is a newer thing that is starting to happen. And so we're not interested in fighting an uphill battle. We're not trying to prove anything to anybody. So we started with educations, where it's very easy to show and, not put any, we don't have to deal with the argument of, are you putting humans at risk? Of course not. We are have a human in the loop expert at all times. Nobody's getting feedback from AI. Sometimes people, when we present, will still miss that point. And so I always like to take an extra moment to emphasize nobody, unless they choose to, and or their provider who is responsible for giving them feedback, is getting feedback without the expert reviewing that feedback. So we are expecting our experts to still be responsible for ensuring the appropriate training of young clinicians.
Excellent. Yeah. And I'm not suggesting, diagnostics being solved by AI. Absolutely, the clinician needs to be in control. But it is interesting to see this progression, just like on autonomous vehicles. Every year they talk about robotaxis being around the bend, but still you need a human driver that's responsible in the loop. Likewise, you need a responsible clinician that guides the decision-making process, but AI can be a support to that process.
Yeah, I can't imagine in the future there won't be a patient will probably be uncomfortable if a doctor refuses to run their case through some sort of software. Obviously, some people really don't want their stuff to go through the internet or be on the internet or on they want paper still. So you always got those people. But for me, obviously it's clear that AI will be a great tool for the future of medicine.
Do you have a sense of whether the educational side, medical education, med schools, or the clinical side, sort of onboarding staff training, is a more likely or easier use case?
Say the question again, sorry. I just want to make sure I understand.
It seems to me like, and I may have heard this wrong, or you may have addressed this earlier, so apologies if that's the case. It seems like one channel is like sort of through med schools, medical training, the problem or program that Sherry was describing at MCC, that are sort of like you've got a trainer that is adopting this versus a clinic or a health system that is kind of using it to train new staff. I don't know if either of those if you've got more users or more traction or a more viable path, or if you're sort of still exploring which of those is your more likely early adopter. I'm curious if there's
I think it's going to be a combination of both. I think med schools or training programs probably fit more of that target audience initially, simply because those are the people that are really kind of already adopting cutting edge technology, are very interested in simulation. They already have the content, the curriculum. They already have the use base, the students that they're trying to train. And again, if we can adopt those integration systems, it can make it very easy for us to get onto those learning healthcare systems or the learning management systems like Canvas, Blackboard, things like that, to be able to get to those things. So I think that is the path that we're on currently. I am very excited about just like healthcare training as well and CME. Again, we're not trying to create the content. We want to put the tools out there that allow that content to be just far richer. And so we're looking at things like SCORM, which are used by like HealthStream, things like that, that would allow people that are building the content there to be able to leverage this type of technology. So again, I think both, but right now we're getting better traction with just talking to schools. But we're eager.
So at a school, kind of going back to the who sets the rubric, or it feels like there's a bunch of different things that they train on. How many people have to like evaluate or set up the training? Like, does it? I mean, and this may be something that from experience, or just the way that you anticipate it working or are going to learn. Like, do you have 20 different specialties at the med school, and there needs to be a specialist at each one that's kind of doing that? Here's how this matches our rubric, that goes through that process of here's what we want you to score against in this kind of. How does that function with the training or the school staff in terms of getting to know your software and what it is that you're trying to do? And
absolutely. So by using like an LMS system, those roles and authentication kind of pass over, so we can see, all right, this is this educator, they're tied to this cohort, this is this specialty, et cetera. And so we can be able to see that. And so we envision that like by creating you're just focused, like you get on this platform as an educator and an admin, you're building your curriculum or your rubric. It's going to be kind of organized around that universe that already has been designed and structured for that school or that program. And so you don't get on there and see, I mean, I guess we have a filter, that shows everything. But the idea is that you get on there and you're getting what you're kind of the scope that you're designing in. And that would be inherited by the LMS. And I think that's where we're going is like we don't want to get into the business of building a whole LMS structure out. We want to be able to just seamlessly integrate. And things like LTI and SCORM do that. They allow us to basically just kind of do the server handshake, and all of a sudden you pass over all the information about how your users are organized, and we just help you focus on creating content and assigning that content, assessing that content, and giving that feedback back into your gradebook.
Aaron, if I'm going to jump in because I'm wondering if you had a slightly different question. So possibly, as far as content creation or the rubric creation, in these environments, don't get me wrong, I'm sure once they get involved, they might want to create some custom stuff, right? But they could just say, hey, I already teach on Monday. Here's the PDF, the one pager I give all my students that we're going to discuss, and we do a group discussion. So they already have that page. So they just simply upload that page to our system. It will create the patient. They can add in additional values and make it unique and do fun research. I'm going to make this person anxious. I want to add this person as a fifth grade reading level. And then I'm going to, comment to my students about talking over their heads. We can mimic these realities and bring it to life. It's impossible to have a group conversation and everybody get the same opportunity, because as soon as somebody starts speaking, it's influencing everybody in the room. So in this situation, we've imagined true before and after at an individual level. I could open up a classroom. Everybody already has their patient. They get 5 minutes to do their simulation. We run through the teaching session. We have our discussions. Everybody ends the class with the same same simulation. You now have a very clear before and after individual level feedback of what they've learned. And so the rubric is the same way. If they have a rubric, we can upload it to our system and it will just create that rubric to match the existing rubrics. So the reason med schools tend to be, or in a learning environment tends to be a little bit lower hanging fruit for us, isn't so much that we won't be really great in the clinic. It's just in the clinic, are you going to ask somebody to do more? Even if it's just a little bit, you have to really demonstrate their time saved and or cost. So if we work with medical educators and they build this into their CME, we just have to have that work really, maybe it's a more fun experience. It's better learning and it's super cost effective. And that's about as good as you can get. But we're not going to be able to just say, here's how you saved thousands and thousands of dollars. On vice versa, in a learning environment where much of their time is consumed by the content creation, rubric creation, and applying that rubric and creating those assessments, we can kind of walk in and say, here's how we save you an immense amount of money and enhance the learning experience. So it's not so much that it's not great for a clinic. It's just you would have to have the right clinic environment where they already, regularly sit down, discuss patients, do grand rounds, and expect to kind of evaluate people, which is why on the clinic side, we've started to look more at our foot in the door as transcript, ambient scribe transcript evaluations, because then we could auto generate customized feedback. Like once they decide areas of concern, you could then auto generate custom experiences to bring that up to par and confirm that you got that result. So it's just now that's a totally different ball game, and now you're claiming you saved them $10 million on a lawsuit that was coming down the pipeline they didn't know about.
Yeah, no, that's great. Thank you. We have time probably for one, maybe two more questions if anyone has one.
I got one. Instead of targeting learning management systems and individual rubrics from medical schools, sure, you've pondered U.S. medical licensing exam, step 2 stuff, those anxious ones that are trying to get through, the clinicals to get to their residency. This is similar in a way to have a separate offering, just like Anki cards and things like that are used for medical students to greatly supplement what they're already getting in their learning experience.
Absolutely. I think the first step is validity. I think we shouldn't be using anything in our national, accreditation process until that's been proven. But that is definitely on my hope and roadmap, is that this becomes a replacement of multiple choice questions, that we really are getting at what is your reasoning and how you're approaching a problem? That is a far richer, more interesting question, and I think will help safeguard practicing clinicians going into the future. So I totally agree.
Great. Well, Stephen and Jared, thank you so much for this presentation. I know that Sherry put some contact in the chat, so hopefully that will prove fruitful. Of course, feel free to reach out to us. I know you guys work with Jim some, and we'll continue to look forward to your guys' continued success. Want to give the folks who have joined since we started a quick chance to introduce themselves. Jeremy, Steve, Patricia, and Tish, I will call on you. So just giving you the heads up. We'll start with Steve Kropp.
Hey, thanks, Aaron. I'm Steve Kropp, the Director of Telehealth at the University of Kansas Health System.
Patricia McDonald.
Hi, Patricia McDonald. I'm with the Healthcare Institute for Innovations and Quality.
Tish.
Hey, I'm Tish Bryant. I'm the Community Integration Coordinator at the Missouri Primary Care Association.
And Jeremy Coe, who may have dropped between the time I said his name and now. So, but thank you for joining anyway. All right. So we will move on to our second presenter. We have Matt Wilson from Spark Change.
Hey, good morning, everybody. Thank you so much for having me. So John Fitzpatrick last week asked me to fill in, I believe, for the company that dropped, and you're all going to be treated to the scintillating topic of healthcare revenue cycle here for a couple of minutes. So give a little bit about my background, and actually let me share my presentation. Give me 1 second. Okay, so my background as that comes up.
We're still not seeing it, Matt.
Still not seeing it. There we go. How about now?
Yep.
All right, perfect.
And it looks like it's in. Oh, now we're seeing your Zoom screen. I think you might have been trying to enlarge it or go to presentation mode.
Does that work?
We can see it, but it's in notes. Now it's in it's in presentation mode where we can see the slide, but we can see like exactly your screen, which shows next slide on the right and notes on the bottom if you have it. I think there may be a
if you go up to display settings up at the top left, see where it says display settings.
I do.
Yeah, just click on that. Let's see there.
Is that better?
That works.
All right, look at that. We got it together. So anyway, thanks for having me. So Matt Wilson, from a career standpoint, I've been in healthcare for about 32, 33 years. History primarily on the clinical side, spent a number of years in the early stages of the electronic medical record. I was an executive at Cerner for about 10 years. After that, I was CEO of a precision health company. If any of you are familiar with Dr. John Spertus at St. Luke's and Mid-America Heart Institute, I was CEO of a company that he founded that used predictive modeling to go project patient likelihood of benefit. And then ultimately, after exiting there, ran healthcare for a couple of large technology companies. So the one of the things that is interesting about certainly the prior presentation, which is fascinating in the utilization of technology to go enhance actual clinical delivery, a lot of what is going on today in terms of innovation and utilization of these technologies is how do we change the way we deliver health? How do we change the way we extend the opportunity for healthcare everywhere? How do we begin to shift our focus in care delivery really to a system of health rather than a system of sick care, which is generally what we have here in the United States. So my entire career largely has been focused in those venues. And as I moved on a bit, I was doing some work with a private equity firm and developing some theses around, again, utilization of technology in some of these more advanced cutting area cutting edge areas. The thing that ultimately I came back to, and it was based on kind of one of the piece of advice I got from a good friend who said, you are always out trying to solve the hardest problems with the most advanced technology. And while it is incredibly, incredibly rewarding, and I just, kudos to the two prior presenters and everybody who spends their time here, we have some fundamental problems in American healthcare that go beyond just simply access to care, the way we deliver the care, and the cost of care. And there's a debate to be had that those are the only things that we should focus on. But if you look at organizations like Oracle and Epic and those that really dominate that landscape, so much of that focus has gone into those areas that what we're leaving behind is the opportunity for these large institutions and small institutions to really continue to function, to continue to not only provide care, but to account for that care, to bill for that care, to collect effectively for that care. We've built extraordinary inefficiency into this model, which elevates that cost, which ends up being passed on to the consumer. So in my professional career, it has been few and far between when I've had the opportunity to work as I do today in an organization where we are so capable of, over a short term, providing such direct benefit to our clients and benefit to our clients that actually leads them to the ability to deliver better financial profile for the institution, and in some cases, reduce that cost of care that they then pass on to consumers. And it's just a very, very different venue and landscape from something that you all likely spend a lot of your time viewing. So I think that's what John thought might be interesting. It may or may not be, but I'm happy to take you through where we are as a company, what we've done, and just kind of this context around something different. So the reason we exist as a company, again, revenue cycle is incredibly, incredibly complex. You have this massive level of complexity that is created between payers and providers and third parties and all that are involved in how do we go simply turn a clinical encounter into a charge, into a claim, into a bill, and how do we get paid for that? At the end of the day, that's what keeps those doors open. And we've muddled it to the extent that it requires this overwhelming waterfall of transaction volume that we're not capable of keeping up with the people, good, strong, smart people that we have working in these revenue cycle and finance operations that just simply aren't able to keep up. And that complexity also leads to a high error rate, a high denial rate, rework that you have to do. What organizations like Cerner and Epic and Meditech, what we've often done is just digitize those manual processes such that we are now using the computer to do what we used to do manually. And we've not really reduced or improved that process to the extent that we're still challenged by those same things. And so you generally have a workforce that is relatively unhappy. You have a challenge in getting cash in the door in order to keep the doors on, keep the lights on, and continue to pass on good quality services, plus a level of satisfaction that you're impacting clinicians with as they're asked to redocument and provide a lot of these things. So for our company, what we do is we address that. And we're going to address that in a couple of ways that begin to impact directly some of the data that you see here, 30 to 40% turnover, an incredible amount of every dollar spent in healthcare goes towards administration. And that's just something that shouldn't happen. There is profiteering that takes place on behalf of companies. There are ways to go solve this, but again, you have a lot of stakeholders who have a lot of money in this game, and what they're looking to do is maximize either for shareholders or for their own benefit, how they do that. And at the end of the day, it's clinicians and patients who ultimately suffer from this complexity and a lot of this dysfunction that exists. So as we come into play, what we're looking to do is we are looking to let's get rid of some of the complexity on the exterior. Let's stop building a workforce that is addressing that dysfunction through throwing additional people, throwing additional workflow, throwing additional processes at that. And let's go use technology. Let's use machine learning. Let's use AI. Let's use the appropriate technology in the appropriate place to go begin reducing that. And so we do that largely in one of three ways. The first way is we do that through analytics. Now, what I'll tell you from 30 plus years in this business, this industry needs fewer analytics companies. What analytics companies have largely done is present in more articulate and visually stimulating ways that a clinician, an institution, a practice has a problem. And we're able to articulate those problems in ways that say, hey, this is actionable. I'm giving you the answer key that you can go use to go improve what you're doing, to go reduce your inefficiency, to go use this data in order to make improvement. But the problem is, and as many of you have largely likely suffered when you've seen analytics that pertain to your own areas, I don't have the time to go do that. I don't have the staff or training or not intellectual, but capacity to go interpret those results, to go know what to do. And even if I did, how am I going to go do that when I'm doing this instead? So our analytics are designed in a relatively unique way to go show where in the continuum of the healthcare revenue cycle, and we're talking all the way from the moment a patient is registered, through the clinical encounter, through documentation, through coding, all the way through the collection of cash. Those analytics are going to show them and us where is every dollar sitting, in what volume of transaction, in whose bucket. If there are 1,200 transactions worth $452,000 that are sitting in this one designed edit, and that edit means I want somebody to look at this and change a 1 to a 0 or check whether or not that 1 to a 0 needs to be changed in order to satisfy this rule for this particular plan that this patient is on. If that's sitting there in that volume, that means someone has to do that. And likely they have a volume of those tasks sitting that they have no hope of getting to that day, that week, maybe even that month. And there's another wave of those transactions coming down the line. And that may happen 40, 50, 100 times through that continuum, again, as you move from that patient access, right? So from registration through admission, all the way through discharge, and then all the way through collection. So our analytics are going to show our clients, where do you have dollars in transactions sitting that are undone? Where do you have clinical encounters that have not been released for a charge because a clinician hasn't completed documentation, or there's some element that hasn't been checked, there's a box that hasn't been activated? So where do all these things sit? So from those analytics then, and I talked about actionable analytics don't necessarily mean you have the time to go do it. We then get into the heart of what our value proposition is, and this is automation. So automation, when we think about that in healthcare terms, especially on the administrative side, we're largely talking about robotic process automation, bots. And many of you have likely heard of that. The challenge with bots in healthcare, in a very, very ever-changing landscape where you have literally hundreds of systems that are functioning inside of an institution from an IT standpoint, the changes made to those systems are numerous and frequent. And every time a system is changed, there's likely something that has to be done to that bot to go tweak that or update it to account for some change in the requirement in order to action that particular thing. So where bots work on binary tasks, so a fax comes in, file the fax here, right? A number comes in, it's always a 0. Those real binary tasks, they work okay. But what we're doing is our automation, we're going direct to the database. We're bypassing that user interface, which is where bots function via what's called screen scraping. And we're going direct to that database, and we will say, based on those analytics, you have 452 transactions sitting there. I can use automation to not only drain the totality of those interactions, of those transactions, to reduce that volume, get those dollars moving. But what I can also do, and this is critically important, I leave that automation in place so that the next transaction and the next transaction and the next transaction are done via that automation. So healthcare has been in this boom bust cycle over the past 30 years around performance improvement. Largely consulting firms will come into the organization, they will spend weeks or months assessing everything, talking to everyone, bringing people out of their workday in order to say, what's your perspective on where your challenges are? What's your perspective on how this inefficiency, runs itself throughout? And frankly, asking, what do you do and how do you help or hinder that process? And then from there, they will provide a recommendation. Often they'll come in. Their objective is largely cost cutting through people. And then when they come out, there will be improvement. They will have reduced costs, and there's likely some benefit to the efficiency. But inevitably, whether it's in a community hospital or in a large national health system, that improvement always regresses and reverts to that prior state because humans generally do what they are used to doing. And so thus, we will spend billions and billions of dollars this year on these performance improvement projects that they are doomed then fated to reduce and regress back to what that norm was. So our core thesis is that as you utilize analytics in order to identify a problem that can then utilize automation to go drive the solution to that problem, and then reassign your workforce in ways that they are not working on very low productivity, very low return items, but instead your workforce is working on higher order functions that they are likely going to be more inspired by, more fulfilled by, that we can now produce a better outcome both financially and from a staff satisfaction standpoint as we go. And then the final thing is from a services standpoint, we're not looking to layer our automation, our technology where that doesn't need to exist. What we do is we come in and we look to optimize your existing systems, your existing technology, and first say, we can configure you in a way that is more optimal, and then we can use automation if that first process does not work. Okay. So I'm going to talk very, very quickly then and very quickly about our journey. This was founded by, Spark Change was founded by four founders originally that all came out of Cerner. It is literally a basement story. They went to one of our co-founders, Dung Tran. They would work in that basement every day for, I believe, 9 months until Dung's wife kicked them out. And they would go through and literally work on LinkedIn in the morning, and then some things that have continued from a tradition and heritage standpoint. They would go to Worlds of Fun, or they would go shoot baskets, or they would play video games in the afternoon because they didn't know what else to do. They didn't know how else to build a company. So 7 months in, they found their first client. Their first client was McLaren up in northern Michigan, very large regional health system. And then from there, what we began down this path of was simply find a problem, go solve that problem, whether it was a system or a people, or you had something that wouldn't work, you had a big mess inside of this one area of revenue cycle, and then ultimately expanding that out to we can be more strategic, sitting at the center of your overall revenue cycle and workflow strategy, and begin to utilize our know-how and technology to go drive the things that I talked about before. So we moved from out of Dung's basement, we moved to Hy-Vee Arena. For those of you who are familiar or have kids that probably play soccer or basketball or those kinds of things, we worked inside of the arena for about 3 years. We're now over in downtown Mission. But as we've evolved, we have begun to take those problems that we're capable of solving, the technology with which we utilize to go do that, begin to bring that together in platforms, those platforms around analytics that now address accounts receivable, now address revenue integrity, now address payer, and help organizations go better prepare for payer negotiations and how payers are adhering to contracts. And then as we move along, our vision ultimately is for what we would describe as a touchless revenue cycle, where we are able to take those encounters, create claims seamlessly, and then drive them through completion. Now, again, what we don't envision is taking humans out of the equation altogether. What we envision is utilizing humans and machines at the top of their skill set to go work where they are best able to do the job, to create benefit, to drive that value throughout, and then to utilize a control center method where they are looking for where are their holdups, where are their inefficiencies, where are their denials, that we need to now go in and figure out how do we reduce that friction, how do we fix that problem, how do we reduce that volume of transactions such that, again, we get flowing again and we aren't stuck in this morass, which is sucking literally the lifeblood out of these organizations as they try to focus instead on where things should be, which is in clinicians, which is in communities, and creating that better system of health. So our ecosystem then, again, from an automation standpoint, it spans that continuum all the way from the very front, from registration, from admission, from scheduling, from all of those things, all the way through documentation, all the way through coding, and then all of the mid and back end revenue cycle that's needed to go collect that cash. A number of those platforms from an analytics standpoint. And then from a services standpoint, we not only provide some IT assistance, including up to outsourcing, but also consulting that helps them organize strategically around how do we do this better and how do we do this in a way that facilitates the real value proposition that we need to drive. So I'll finish with a couple of things. Number one, where do we fit from a competitive landscape? From a competitive landscape, you often see analytics companies. You have these bolt-on vendors that are, one-off. We only work on claim statusing. We only work on prior authorization. We only work on revenue integrity and telling you, how you should get paid. You have outsourcers that are just simply, it's this, funny statement, your mask for less. The same level of efficiency sits out there in the big R1s and ensembles or even smaller outsourcers, because they're still subject to these manual workflows and not automating where they could be. And instead, they produce the same error rates, same denial rates, et cetera. And then consulting firms, large and small, that will come in, do these assessments, throw people at the problem without leaving any kind of sustainable performance improvement that then goes forward and they don't have to go back and repay for. We end up sitting in the middle of these. And what our clients have found is that we're able to effectively replace many of these in a process that we call vendor rationalization, which is you can do under our existing contract what you are paying tens of thousands of dollars a month over here, and you don't have to pay any more for us to do it, because we're able to bring people and technology to bear in a way, in a synthesis, that will actually go do that easier, faster, better, produce better outcomes without having another vendor relationship to go manage. So from a methodology standpoint, what we're doing is, I call it, going from a fire, fighting fires, clearing brush, and planting forests. So often when we go into organizations, they are melting in some form or fashion. They are incurring losses from an organizational standpoint. They are hemorrhaging cash. They need to find very quick ways to go bolster things. We're able to surge resources and technology to that point, go find ways to very quickly turn around and eliminate the problems that they were having or the problems that they are having. But at the same time, what we don't want to be is that process that I described prior, where we'll go provide a temporary fix, but then when we leave, you're going to regress right back to that same state. Instead, what we're looking for as we go along, as we get in with their billers, as we get in with their coders, as we use technology to go look for where the best opportunities, the highest order opportunities are to go generate cash quickly, to go reverse losses quickly. We're also looking for places that we can optimize their current technology stack, where we can use our automation to go then leave a footprint, which is going to begin to clear out some of those future fire opportunities and then go sustain that performance once some of those fire and those flames are tamped down. And then when we talk about plant the forest, it is not only implementing the infrastructure from a technology standpoint, not only beginning to use machine learning and AI in ways that allow the system to begin to drive some of that improvement on its own, but how do we re-envision the way we utilize staff? How do we re-envision the way we now function in a world where we don't necessarily need human touches to go drive this, but we're able to surround that with ways to go help clinicians and reduce their documentation burden, reduce the burden of others as we collect, reduce the burden and improve patient experience when from a self-pay standpoint, anticipating the ways that they would need to pay, anticipating what they can pay. How do we take that full process and how do we turn that into a transformed state that really gets us where we need to be from a financial standpoint, so appropriately more of what we do fades into the background and we can spend far more time working on the far more important challenge of turning, again, a system which today is focused on illness and sickness, injury, and turn that into a broader system of health. So our clients today, so we are what you would describe as a growth stage company. Thankfully, we're out of the seed and initial stages. We do have clients all over the country. Here locally, we work with University Health Truman. We work with North Kansas City. We work with Lawrence Memorial. And then we have, again, large regional health systems in the upper Midwest and the Northeast, University of Southern California in the West. And we continue to grow at a fairly rapid state, both in capabilities as well as in the breadth of technology that we can offer. So I'm going to stop there. This is unfortunately not something that you necessarily demo and show. Automation is something that works at a technical level in the background. The most fun would be to see, a volume of things and hit a button and it goes to zero. But from an automation standpoint, this doesn't really lend itself to show and tell. But hopefully that tells you a bit about what we do. It tells you a bit about why we do what we do and kind of how we're trying to make a difference in the broader healthcare landscape. So with that, I'll turn it over for questions, or Aaron, back to you.
Thanks, Matt. Appreciate it. That's a great presentation. Let's open the floor. Any questions for Matt?
Yeah, a great presentation, Matt. I actually just gave a talk to the American Association of Medical Coders. And in it, as I was preparing for that presentation on how to use AI, and one thing here, it was here in Kansas City, and in the audience, I asked how many people are using AI, and very few actually are using a lot of AI tools for the medical coders. But in the research, there's a real challenge of the AI bots by the insurers starting to deny more.
Yeah.
But then they're starting to have more appeals. And and actually use the providers as well as the patients are using AI to get the appeals. And if you appeal, you're like right now, it's like 85% of appeals are successful. So how do you see, AI, being used both by the insurance companies as well as by the providers and patients? And how does your solution fit within all these bots that are running around, trying to get approvals and denials of what's going on?
Right. So with respect to our colleague, I know there was somebody from United Healthcare that was on the line as well. It's a technology arms race, Doug. I mean, the investments are going in an effort candidly to defeat the other, rather than some sort of symbiosis where they're working together to reduce the administrative burden and conflict on both sides. There's been legislation introduced to, eliminate or reduce pre-authorizations, this claim statusing where, we''ve come up with automated ways for somebody to literally just check, have you received my claim and have you paid it? We need to focus on some ability for insurers and providers to work together in ways that's using technology to improve their own workflows, rather than to focus on tricking the other into paying or into, denying what is going on and what has been paid for care. We need to utilize, and I think, and you mentioned ambient listening earlier, there are ways to create a more streamlined path from, the actual clinical process all the way through the submission for payment, in ways that I believe both payers and providers would agree, would be healthy and would be good. And I believe that there are reductions in both the reimbursement required and the dollars going out on the part of the payers that could take place. But right now, there is no real solution on the horizon for that collaboration because you largely have two stakeholders who today are at odds, who today are mistrustful of the other. And I know that there are certainly cases and there are certainly groups and stakeholders that would argue that no, indeed, we are working together. But on the whole, when you go to industry meetings and you have a room full of providers or you have a room full of payers, it is all about we must get better technology in order to defeat that other room. And that is just a largely unhealthy and certainly, I would say unsustainable. But the fact of the matter is there is money in dysfunction. There is money in going and solving these problems. So because reimbursement benefits different buyers in different ways, because today under the healthcare big top, under the marketplace, it is very, very difficult to define who the buyer and who the seller is of those services. You have so many different people who have financial gain in this process that it's very hard. And that's kind of a disheartening message. It's a disheartening statement. But that's the reality today. And I do hope that there are groups of people that are working on much better solutions because we have to get there.
Well, thank you. Yeah, I put in the chat. There's J.P. Morgan actually had a report called "Sick as a Dog" and talked about this issue. Also talked about the healthcare system not making a lot of money, highlight those in the chat. But this is a problem that we have to fix because unfortunately, what's happening is. Like the Affordable Care Act, rates are going to be going up, 20, 30%. People are going to be dropping out of the insurance. And this only raises more issues when people need care.
I mean, GLP-1s are going to drive insurance premiums through the roof. You've got today, we are sitting at around 19% of our GDP goes towards health, literally trillions of dollars, and estimates are anywhere between 30 and 35% of that is administrative waste. Can you imagine, and for those of you that are on the front lines doing work inside of the communities and with those that are underserved, can you imagine returning a fraction of those dollars into the ability to engage the community in a broader system of health? Can you imagine the ability to go take those horrifying stories of 2.5 mile radius and a difference in 20 years in life expectancy? And again, we don't think about, and candidly, I did not. I was on the clinical side of the world and just kind of thought a bill was a bill and, somebody would get it and somebody would pay it. But what I found is that there's an inordinate amount of mind share that's going towards how do we keep these hospital doors open. I mean, we work with University Health and everyone knows, I think it's no secret, that they run on just an incredibly fragile financial ecosystem where literally they have only a couple of days cash on hand before they have to close the doors. And so we work directly with them in how do we help you create efficiency? How do we help you bring more dollars in the door that you were owed? It's not how do we help you manufacture more dollars. It's not how do we help you screw more of your patients, more of your consumers in ways that get them to pay more money. But it's literally how do we get state Medicaid? How do we get Medicare? How do we get the commercial insurers? How do we get you to be paid what you owed? And candidly, as we look at some of the data that we present from a payer standpoint, the sad fact of the matter is, and again, with respect to these organizations and health systems, what St. Luke's is paid for a particular procedure is more than what University Health is paid for a particular procedure. So arming these organizations with data, utilizing automation to get a better baseline on what it actually takes and what their actual operating costs look like, give them a much greater ability to go price their services, to go defend the price of those services, to go get equitable payment for those services from payers, and then to, again, reduce the instance of erroneous billing or reduce the instance of, calling someone, when they don't owe money and creating stress in that world. So again, what I've come to learn in being an executive with a company like this is not just about dollars and cents. This is not just about, the administration of healthcare. Ultimately, healthcare finance gets to the heart of how we do a better job in delivering care and creating a system of health and engaging communities.
Thank you.
Great. Other questions for Matt? I assume, Matt, that, most health systems have, or maybe all have someone who's sort of has revenue cycle as their job, I think. Is that where you get in? Is that sort of your main and first touch point, or do you find other places to be more effective?
We would typically start with a CFO, with a vice president of revenue cycle. We are often brought in by other organizations who know that particular institution is having a problem. Some of the companies that, in some ways we threaten to displace often will bring us in. We will spend a lot of time helping get data in and out. That is something that we don't talk an awful lot about, but we do help move data around from a clinical standpoint where interfaces aren't capable of doing that. We're able to move data external to the system to get it in the hands of clinicians and users in other areas. So there are other points of entry, but largely we tend to come in the financial executives that are looking for ways to create efficiency and go reduce their operating costs.
Great. Thanks. Anything else? Okay, well, we are about up on time here. Again, thank you, Stephen, Jared, and Matt for these great presentations. I don't think Jim's still on, and he may know who our presenters are next month. It sounds like CarePilot may be one of them. I should have probably been a little bit more on top of things and looked that up before now. But we will be back the last Wednesday in September from 8:30 to 10, and look forward to seeing those of you who can make it then. Thanks very much.
Thanks, everybody.
Thank you.